Hey, welcome back. Today we are looking at Chapter 12 in your textbook, On-Field and On-Court Care. This is actually a little bit of a scaled down lesson compared to what's in your textbook. As you'll find, the Prentice text is very, very thorough, so going over everything in that textbook is a little beyond the scope of this class. So I wanted to do my best to narrow that down just to some fundamentals. The nice thing to consider about this particular lesson is that these are going to be principles that we carry over into much of what's left in the course. So we've talked about a lot of the basics of the profession. We've looked at a number of different aspects that are general to athletic training, and from here on out the goal is to look at individual body parts and look at specific injuries and assessment and rehab techniques. And these on-field and on-court care concepts are universal to all of them. Now, with that said, you'll also notice in your textbook that there's a pretty heavy emphasis on CPR. This isn't a CPR class. I would definitely encourage you to pursue a CPR class. I'm an instructor for the American Red Cross. American Heart is another, but you won't receive a CPR certification for taking this course. So we basically just looked at all the other stuff apart from CPR, more of the first aid type things, and that's really the focus of what we're going to do today. So in particular, we're going to take a look at the primary and secondary survey, identifying what our immediate threats to life are, and then looking at both cardiac and soft tissue injuries. And then we will spend a little bit of time looking over this concept of police, which is how we manage our soft tissue injuries. All right, now our primary survey consists of establishing the status of our patient, and we do that by looking at whether or not they have an airway, whether or not they are breathing, whether or not they have a pulse, and then establishing their level of circulation. So the mnemonic we use for that is ABC LOC, airway, breathing, circulation, level of consciousness. So we do this by look, listening, and feeling. We attempt to palpate pulse. We'll also establish the level of consciousness that our athlete has. With our secondary survey, we are trying to decide whether or not this is something we're going to manage ourselves, or whether or not this is something we need to refer right away. So in EMS, what we talk about here is whether or not we're going to stay and play or load and go. If this is a true emergency, then we are going to look at getting them out of there as rapidly as possible. If it is a non-emergent acute injury, then we're going to try to figure out if there's something we can do to assist with that athlete's care. Okay. Now, lots of times in athletic training, we're trying to make basically one decision. Okay, and a number of decisions that kind of spiral off of that. But our primary decision here is whether they are going to participate or not. And so our first question there, stay and play and load and go, is our very first decision that we make. If it's stay and play, then we're going to decide what we can do to assist. Whereas for a non-athletic population, we're probably not as concerned with participation status. So if you're at the mall or you're out at the movies and you deal with an acute injury situation, we're not trying to figure out whether or not that person needs to return to shopping or whether or not that person needs to return to the movie. It's basically, are they going to the emergency room or are they not? Beyond that, really doesn't matter to us. So during our primary survey, the first thing we're going to do is take a look. We're going to observe. We want to see their body positioning. Is it clear that they have maybe a dislocation or a fracture? That airway, breathing, circulation is critical as well. So we can observe body position before we even arrive on the scene. As we are approaching that patient, we're looking to see, are they prone, face down, supine, face up? Is there obvious deformity? That kind of thing. With LOC, we are looking to establish how alert they are. So this AVPU scale comes into effect. So alert means they respond to our question appropriately. V in AVPU stands for verbal, whether or not they can reply to us, even though they might not make sense. So if I arrive on the scene and I say, hey, are you all right? And they say, yeah, I'm okay, just a little shaken up, they're alert. Okay. If I arrive on the scene and say, hey, are you all right? Can I assist? And they say November. They're responding to verbal stimuli, but they're not responding appropriately. Pain is our third level down the list here. This means they don't reply to verbal stimuli, but if I pinch them under the tricep or brush their cheek, then they probably respond. And then U is unresponsive. We're not able to elicit any kind of responsiveness there. We also want to make sure they don't have a spinal injury. Okay, and if we suspect cervical spine involvement, actually any spinal involvement, then we're going to manage this a little bit differently. We're going to immobilize, we're going to spine board them and take those precautions. We also have to consider whether or not there are any equipment considerations that we need to take into account here. If they're wearing a football helmet and shoulder pads, they've got the mask on, and they're unconscious, then there's a very high likelihood they're going to vomit at some point. So we don't want them to aspirate, asphyxiate, and we've got to figure out how to get that face mask off. A little bit later on we'll talk about spine boarding in more detail, but just suffice it to say that if they've got that equipment on, it's going to change the way that we manage them, whereas if they're a basketball player, they're just like any other athlete. All right, so consider this situation. There's a collision at second base between the shortstop and a base runner. Shortstop's trying to make a play. The two collide. They both they both collapse, and they're both on the ground. You're covering the event as an athletic trainer. You arrive on the field, neither of them are moving. What do you do? Okay, this speaks to the question of triage. So I have to pick one or the other. Chances are, if I'm covering that event, I'm covering it for a team, and my team's either on offense or defense. So I will probably attend to my athlete first, and then when I've made sure that I've done that primary survey, then if no one else is rendering care to the other athlete, I'll quickly check them to see if they need an immediate transport. Okay, if I suspect a cervical spine injury or they are unconscious. Not moving isn't necessarily a threat to life. Unconsciousness is. So we're going to summon EMS. Okay. Instead of a collision, consider this. We've got a non-traumatic, non-contact injury, or a non-contact situation rather. We're at basketball practice and our power forward collapses. We run to his side, find that he's not breathing and he doesn't have a pulse. What do? We summon EMS. This is not a stay-in-place situation. We're going to render care, but this is very much a load-and-go situation. No amount of proper care on our part in this situation is going to get this individual what they need. They need an AED. They need transport to advanced medical care as rapidly as possible. Okay. So we're going to check vitals. So that level of consciousness is one of them. ABC, we're checking multiple signs of their vitals. Okay, so their pulse, we're going to check that. We'll look at specifically, every one of these we'll look at specifically what we're going to look at here. So the first thing, some suggest that this AVPU scale isn't necessarily the best for athletic injuries. There's a big gap here between alert and verbal, with the emphasis on concussion assessment, recognition, and management. This may not be the scale we use, but in EMS this is used pretty regularly. We probably want to have a little bit better handle on how impaired is that verbal, or how impaired is their alert. For all these vital signs, we want to do what we call serial assessment. If we do something in series, we do more than one. So if we monitor their level of consciousness, if we check it initially, there's no guarantee that it's going to be the same. And in many instances, if they've suffered a head trauma and they've got a bleed, then their vital signs are actually going to deteriorate over time. So monitoring these vitals every few minutes allows us to trend these things, so we can determine, yeah, they're getting better, they're resolving, or no, they're getting worse, and we need to, something we thought maybe we didn't need to transport, it becomes clear that we do. Okay, we don't want to assume that there are no changes here. So by monitoring them serially, we are ensuring that we are documenting this. Okay, so with our pulse, with our adults, we're going to check typically carotid in the neck. We will also check distal circulation in their radial and their dorsal pedal if we can get to it. Lots of times with their footwear, we can't. Just to make sure that their peripheral circulation is okay. So we're going to document their pulse rate, their pulse quality, how strong, and the pulse rhythm, how regular is it. On an infant, we don't want to check their carotid. A, they've got a big head and no neck, so it's kind of hard to find their carotid. B, their carotid artery is very small to begin with, and we don't want to occlude blood flow to the brain. So for that reason, we will check brachial pulse in an infant. So what we're looking for here is the rate initially. So we're just going to count. So we need access to a watch. You can use a stopwatch on your phone. Do a 15-second check and multiply by 4. Anything less than 60 is considered bradycardic. So that means it's slower than average. And in some well-trained athletes, and many well-trained athletes for that matter, especially your endurance athletes, they're going to be bradycardic to begin with. So that's not necessarily a big clinical warning sign, but if you've got someone who is clearly deconditioned, they don't train, and they're bradycardic, then that would be something we would take note of. Greater than 100 is considered tachycardia. And again, this is resting heart rate. So if we come on the scene for an athlete, that basketball player, he very well may be tachycardic because he was participating in practice. That doesn't mean that's his resting rate. So these terms depend on resting rate, not necessarily exercise rate. So we also look at the quality of the pulse. How steady is the rhythm? Are there gaps or lapses? How regular is it? And is it strong? Can we feel it easily, or is it kind of weak and thready? Another part of the secondary survey is respiration. So we want to see, is there even movement in the chest? Both sides are rising and falling normally. Are there any abnormal sounds? In the case of an automobile accident where they've sustained chest trauma, they might have what's called a sucking chest wound, where we can actually hear air entering that pleural cavity. And flail chest means that one side rises while the other side falls because we have a lack of continuity there. So our normal respiration rate is going to be between 12 to 20, and just like in terms of medical terminology with cardiac function, we use those same terms for respiratory function. So bradypnea is 8 to 10 respirations per minute, and tachypnea is more than 20. So our normal rate there, 12 to 20. When I read that, I always wonder, well, what if they're 11? That's more than bradypnea, but less than normal. I don't know. Just the kind of things I look at. Skin observations, another thing we will do here. We take a look, is their skin flushed? That would indicate they've got vasodilation near the surface of the skin. We'll see that oftentimes in an athlete who's exercising in heat. That may be normal. Is it pale or ashen? That would indicate that they're shunting blood away from the surface of the skin and moving it more toward the core. If they're cyanotic, then they have kind of a bluish tinge. That means they're perfusing poorly. Jaundice, they can have kind of a yellowish tinge. That might indicate they've got a liver condition. What is the skin temperature? So we use the back of the hand to feel, see if there are any abnormalities. We also look to see if their skin is cool or clammy, moist or wet. And then lastly, turgor. This is basically pressure associated with normal circulation. So with turgor, we look to see how readily does the skin return to normal when we either pinch it or otherwise manipulate it. And in the case of a patient who's medically frail, they'll have poor turgor in their skin. All right, some other things we look at. Pupillary actions. We look specifically at the eyes. We're looking for a couple of things. There's two different mnemonics here for us to recall. One is called Pearl. We look to see, are the pupils equal and reactive to light? And then Perla is another one where basically means the same thing. Pupils are equal, they're round, they react to light, and they are accommodative. Either one's fine. You may see one used one place, one used another. but they refer to the same thing. The second one just adds in whether or not their pupils are the proper shape. We also look at their blood pressure, 120 over 80 being the norm. You see that 120 over P, that is a palp blood pressure. So if we're having trouble hearing, we use the stethoscope. So basically with the blood pressure, if you're not familiar with it, we're going to use the cuff, we're going to inflate it up to somewhere around 200 millimeters of mercury, something along those lines. And when we do that, we're basically clamping the artery closed. Okay, the pressure of the cuff does that. As we let pressure off, we'll see that needle drop, and as we're listening, we will start to hear the pulse again. As that artery opens up just enough to let blood spurt through, we can hear the difference. It goes from no sound at all to a pulse. So that is our systolic blood pressure. That's the pressure that is in the system when the heart's contracting. As we continue to let pressure off, we'll hear that change when we go from, it's almost like you consider your garden hose and it's got a kink in it. It will sound different. It'll kind of spurt and spew as it's kinked, and as we eventually let off all the pressure, it will sound like normal flow. Well, that lower number where we hear normal flow again is the diastolic number. And the reason we have 120 over palp is if we don't have a stethoscope, or we're in the back of an ambulance, or we're in a crowded arena and we can't hear, we can actually palpate the distal pulse. So that upper number is when we go from no pulse at all to being able to feel the pulse again. And the only way we can hear the diastolic is with a stethoscope, so we wouldn't be able to check that one just through palpation. Hypotension, hypo meaning below, tension meaning pressure. Hypotension would be anything below that 120 over 80. And then hypertension, very common in our society due to processed foods and sodium intake. Really three different levels there. Pre-hypertension, stage 1, and stage 2 hypertension. You can see the numbers there. With temperature, we look for 98.2 to 98.6 orally. If you are a licensed certified athletic trainer and we're considering heat stroke, then the rectal temp is considered the gold standard. Alright, some other things we look at in the secondary survey. We look at how the patient's moving. Are they hemiplegic? Do they have normal motor function and normal, we might check fingers and toes. Can they wiggle and move those? Or do they have a weakness or an inability to move? Posturing would indicate a head injury. So if we see them kind of locked into this elbow flexed, wrist flexed position, or elbows extended, wrists extended position, that may be an indicator of a serious neurologic injury. We also look for abnormal nerve response. Do they have any numbness or tingling? So we'll have them wiggle their fingers and toes. We also do a quick check to see, does both sides, do they feel the same? Fingers and toes feel the same. We will also do what are called trauma-focused assessments. So we've done our primary survey, we've ruled out immediate threats to life. We've done our secondary survey to rule out potential threats to life. Maybe they're not here yet, but if we leave it untreated, it can be. And then from there we go into what are called trauma-focused assessments, depending on where the trauma occurred. So there's a head, neck, and face, a chest and abdomen, and an extremity trauma-focused assessment, TFA. So with the head, neck, and face focus assessment, we spend a little bit more time looking more closely at the head, neck, and face. Okay, so we've already looked at pupillary action, but we're going to check closely for signs of bleeding, cerebrospinal fluid leakage, a battle sign, which is bruising behind the ear that might indicate a skull fracture. We look for raccoon eyes, where they might have obvious signs of trauma around the orbit of the eye. Hyphema and rhinorrhea, blood in the eye, or nosebleed. We'll look for those. We can do a quick cranial nerve check. Cranial nerve 2 would be visual acuity, so I'll have them look at the far scoreboard. For cranial nerve 3, the oculomotor, I look at their pupillary action. For 4 and 6, the trochlear and the abducens, I have them track my finger. Okay, you won't learn the cranial nerves in this course, but at some point, especially if you're doing athletic training, you will, and you'll learn how to quickly assess them. If we have any of the following, then this is an immediate referral. This is a load and go scenario, even if we didn't identify a problem to begin with. Once we identify this, we will. If they've got a complex laceration, we know the face is highly vascular, the skin's relatively thin, and scars very easily. So anytime we've got something that needs to be sutured, then we're going to send that. An orbital hematoma, something like this, it's just a black eye. Well, it could also involve other issues. We want to rule out the possibility of a skull fracture, concussion, other things like that. Hyphema, we've got blood in the anterior chamber of the eye. This will have to be appropriately dealt with as well. And corneal abrasion, where they've got a scratch, that's going to have to be referred. Manage or refer PRN means as needed. If they've got a foreign body, we'll see this a lot of times when athletes play on the artificial grass surfaces with the rubber infill. They'll get a chunk of that junk in their eye. That's not necessarily one we have to refer right away. Lots of times we can irrigate that out, but where this is particularly problematic would be, the athlete gets it in their eye and they rub it and they embed it, and we can't get that out. Then that would have to be referred. They might even have to be sedated, and we have to irrigate that out, otherwise extract that foreign body from the eye. But we definitely don't want them to rub it, because there is a chance that could turn into a corneal abrasion. Alright, with our chest and abdomen focused assessment here, we're concerned that they've got some sort of closed trauma. We can't see it, but they're bleeding internally. Okay, so we're going to observe, we're looking for symmetry, we're going to lightly palpate around each of the quadrants, understanding what's in each of those quadrants. We're also going to palpate and check the sternum. We're looking for possible rib fracture, costochondral separation. If they've got signs of abdominal distension, that may indicate that they've got some sort of organ or abdominal visceral injury. Rebound tenderness means it doesn't hurt when we press on that spot, but when we let go, it hurts. That's a sign that they've got an intra-abdominal injury, so we would refer that. If they've lost bladder control, then that may indicate a spine injury, so we would refer that as well. Alright, so that leads us to musculoskeletal assessment in the extremities. So we do this in a very systematic way, and we'll use this mnemonic for every other body part. So we'll do foot next week, and we're going to use this HOPS approach. The first is history. HOPS, H-O-P-S. History and background information. We want to determine the likeliest source of their pain, or the likeliest source of their issue, before we even put our hands on them, before we even put our eyes on them, for that matter. So we're looking for subjective info, things only they could tell us. There's no gauge or scale or measurement device that exists that allows me to check your pain, or it allows me to check your sensation of tightness. That's strictly based on what you're telling me if you're my patient. I'll eventually look for objective information, things that I can measure, your range of motion, your amount of joint laxity, those kinds of things. But in the history, I'm looking very much at the subjective info first. I'm also considering things like what previous injury have you had, if you had anything, what was done for it, did you have surgery, have you had medications, those kinds of things. And then I'm also asking about this particular injury, how did it happen, are there biomechanical issues or anatomical issues in play here. From there, that's when I start to look. I'll do my observations. These will be based on within the patient, so I'm looking for symmetry bilaterally. I'm also looking for obvious signs of deformity from a standard patient, whatever that means. From there, I go into palpation. This is where I'm looking for provocable tenderness, so if I poke on it and it hurts, and I'm also palpating for deformities or abnormalities, one side compared to the other. And then from there I go into special tests. And honestly, we'll talk about a few special tests in this class, but it's really beyond the scope of a general overview in care and prevention to look at a whole lot of special tests. If you're in an athletic training program or PT school or med school, then you'll spend here in our program an entire year in 3 different courses on eval. So we'll just look at some of the basics in here. We will do a focused history when we are doing that history. So instead of just randomly asking the patient questions, when did this occur or how does it hurt, we'll use this standardized approach. This OPQRST mnemonic allows us to make sure we don't leave anything out. We're very systematic in our history gathering. So first is onset. What happened? How did it start? What led you to the point where you had to be here? Now, in some circumstances, we already know. We saw it. It happened right in front of us. But for a patient who comes in with pain, we don't. We didn't see that. Next is the P, provocation. What changes it? What makes it worse? What makes it better? Every time I run on a road, it makes my knee hurt. But when I run on a rubber track, it doesn't hurt as bad. When I run on an elliptical, it doesn't really hurt at all. That's an example of provocation. From there we go into quality. Describe your pain. Is it sharp? Is it dull? Is it localized? Is it diffuse? Where does your pain occur? Those kinds of things. R can mean one of several things. Does it radiate anywhere? My shoulder hurts, but as I continue to throw, I start to feel it down in my wrist. Region, is it isolated to one particular spot, or is it the entire area? Or sometimes people leave this to mean relief. What makes it better? S is for severity. Here's where we attempt to have them objectify their subjective information a little bit. Rate your pain on a scale of 1 to 10. 10 being the worst pain you've ever felt, 1 being no pain, or 0 being no pain. And then time. Do you remember when the symptoms first began? We could, instead of using OPQRST, we can use what's called the sample history. And if you've done American Red Cross, first aid and CPR, you may have seen this sample listed there. So S, signs and symptoms. What's their chief complaint? That CC means chief complaint. Where does it hurt? A, allergies. Do they have any medical allergies, any environmental allergies, sulfa drugs, fill in the blank there. M, medications. Are they taking anything? This could even include things like supplements and over-the-counter meds as well. P stands for past medical history. So you see the overlap here between our OPQRST mnemonic and the sample mnemonic. L would be last oral intake, especially for transporting them for care, and this is why American Red Cross would use this, is for rendering CPR. Knowing when that last oral intake was may be pertinent. If they're going into surgery, the anesthesiologist would need to know that. Or if we're concerned that maybe it's food poisoning or something like that, that could be valuable information. And then E is where they actually describe the event. Some other things we look at here, we'll look at each of these in turn. Cardiac emergencies, soft tissue, bleeding, shock, skeletal injuries, and then police. So with cardiac emergencies, like we said, this isn't a CPR class. I'm not going to try to teach you CPR over the computer. It's really a skill you need to learn, and you need to learn it in person. But the keys to this cardiac chain of survival, first of all, is early access. We want to activate the EMS system as rapidly as possible because time is of the essence. For every minute that passes when someone's in cardiac arrest without an AED, the odds of survival decrease by somewhere in the neighborhood of 7 to 10%. We're not going to get them defibrillated unless we get early access. Okay, so if someone collapses at work, they're working all by themselves out in their garage, and they're not discovered for 30 minutes, then we don't have early access. Their odds of surviving that are very low. Whereas if it happens in an office, we see it happen, we activate EMS right away, start CPR right away, and have a defibrillator handy, then their odds go up significantly. The last link in that chain is early advanced life support. Okay, so we've done all the things right on site. Now it's time to hand them off so that they get advanced care. This is critical to the likelihood of survival after they suffer from sudden cardiac arrest and SCA. Okay, so signs and symptoms of a heart attack: chest pain, pressure, kind of crushing pain, especially in this left shoulder, arm, jaw area. That's referred to as Kerr's sign. They'll also describe weakness, lightheadedness, feeling faint, dyspnea or difficulty breathing. Angina is a condition where they will have a lot of these similar symptoms. Lots of times patients that have had angina, they'll have it periodically. It's almost like heartburn. It's just a condition that kind of comes and goes from time to time. So if we're concerned about that at all, treat it like it is a heart attack. Okay, I'd rather send a patient that I was uncertain of and them end up not needing management versus leaving someone at home who did. All right, with soft tissue injuries, we've got to beware that we want to observe universal precautions. We'll talk about that in the next screencast where we talk about infectious diseases. But with wound cleaning, we want to be as gentle as possible. Okay, we want to save as many of those damaged cells as possible. Irrigate it with low pressure. That again is going to help maintain as many of those as possible. In years past, guilty as charged, I've used hydrogen peroxide. I've used various types of more aggressive disinfectants. Peroxide probably being the one I've used most frequently. Alcohol from time to time. Wound cleanser, this isotonic wound cleanser, sterile saline is probably as good as anything. It's not cytotoxic. Iodine can be, peroxide can be. We can use that in, away from the wound. So I've got a cut on my hand here. I don't know if you can see that. I wouldn't want to clean right by that wound with iodine or peroxide. If you ever go see surgeries, they'll use iodine before surgery, povidone iodine solution to disinfect the area. But there's no injured tissue there. Okay, if we've got a cut already, we've got cells near that border that are holding on for dear life, and cytotoxic disinfectants could potentially make that worse. So we don't use those near the wound. Debridement, we usually do this through irrigation, much like we talked about with the foreign body in the eye. I'll try to flush that with sterile saline as best I can to get it out. Same thing holds true for a cut. I'd rather irrigate that out with sterile saline as opposed to trying to remove it. Now, sharp debridement, on the other hand, is where we actually cut tissue away. This may be outside of the scope of practice for some athletic trainers. We'll see this oftentimes with blisters. So you'll get this, you've had this before, you keep a blister covered, it gets kind of white and soft and wet, and it just kind of lingers. It won't dry out, won't heal. Well, that tissue around the border is basically dead, and all it's doing is prolonging the healing process. So you may have done this yourself. Take a pair of fingernail clippers and trim that lip of dead tissue away. Kind of gross. I'm making a face just thinking about it. But that may be actually against state law for an athletic trainer to do that, because we're actually cutting soft tissue. And that may be considered practicing medicine without a license. We can use dressings to help prevent or minimize infection, but like we said with the blister, sometimes it's best to just leave it open and let it air out and dry if it gets overly wet. We're going to use what are called universal precautions, or body substance isolation. So you see that UP, universal precautions, BSI, body substance isolation. We're protecting the patient from being infected by us, and we're also protecting ourselves from being infected by the patient. We're basically treating every wound as though if we were to touch it with our bare hands, we're going to cross-contaminate one another, and we don't want that to occur. So in this case, you see there's a wound. It's been covered with sterile gauze. There's direct pressure being applied by a gloved hand, and presumably it's being elevated. Elevation reduces blood pressure, which reduces the amount of bleeding that occurs. If bleeding continues, we can also use pressure points to temporarily occlude blood flow and assist the clotting process. If it's not external bleeding, we can't see it. Say they took a blow to the chest or the abdomen. My chest is here, my abdomen's here. If they've taken a blow to the chest or abdomen and they've got bleeding inside the body but no obvious signs of bleeding outside, then the only thing we can do is monitor their vitals. Is their blood pressure changing? Lots of times in the case of a patient who is crashing on us, we'll see what's called a widening pulse pressure. Their systolic pressure will climb and their diastolic pressure will fall because there's a leak somewhere within that vascular system. So the fluid volume that's left is leaking out, so that diastolic number starts to tank on us. Now, shock is a medical emergency. We see this in cases of severe bleeding, cases of fracture, internal injuries. There are several types, and I've listed those out for you here, but the risk is the same: death. This is not something we want for our patient. We want to treat for this and transport them as rapidly as we can. So signs and symptoms of shock: we see a low blood pressure. Their systolic dips below 90. Their pulse is rapid and weak. They're attempting to circulate more blood. It's basically what's happening with shock is they aren't getting oxygen to the tissues that they need. So the body tries to compensate for that by increasing heart rate. They're usually pretty drowsy and sluggish. They don't have enough oxygen going to their brain. Shallow and fast breathing to try to keep pace with that rapid pulse. They're trying to oxygenate more blood. Skin will usually be pale, cool, and clammy. They are conserving resources, if you will, and shunting blood back into the core. So treatment for this, we're going to elevate the feet. That's going to assist the passive return of blood from the lower extremities back into circulation, and maintain temperature. So we would throw a blanket over them. That's going to assist them in combating these symptoms. With skeletal injuries, we're really considering some basic classifications. Like I said, we're going to look at several specific examples of these as we get into each body part. But for now, we just know fractures can be incomplete or complete, where they're either broken all the way through in the case of a complete or a partial in an incomplete. Displaced means that it's out of alignment, whereas a non-displaced, we see that fracture there, but as long as we cast that and immobilize it, it's going to heal nicely. This one won't. It needs to be reduced where it's put back into position. With an open fracture, that bone end protrudes out of the skin, whereas with a closed, it remains intact. And then with a compound fracture, we have multiple fragments in that area. Okay, so usually our mechanism of injury here, we've either got a direct, where there's a fracture that occurs right at the place where the force was applied, or indirect. So a direct would be, I took a line drive to the face. We see this. So we get a fracture in the maxilla. Okay, that would be a direct fracture. Whereas an indirect, I planted, and due to the forces that were involved when I rotated, I got a spiral fracture in my tibia. Okay. Another type of fracture here we see is an avulsion. This is where the ligament is so strong that it actually pulls a little chunk of bone off. There's several other examples of traumatic fractures here. Comminuted, where we've got kind of the shattering, a linear that's parallel to the long axis of the bone. Transverse non-displaced, that's in the right place. It's perpendicular to the line of axis, the axis of the bone. Oblique, we see that it's kind of not really in the classic transverse plane. Spiral, there's a rotary component. So lots of different types here. Some are more involved and take longer to heal than others. Some other skeletal issues we have to consider. A dislocation, this is where the articulating surfaces are forced out of normal position. These may reduce on their own, considered a spontaneous reduction. These may stay out of place. So you see a shoulder dislocation and that stays out of position. It's not necessarily any better or worse than one that reduces on its own, but if it's out, then we have to figure out a way to get it back in. That's reducing dislocations is beyond the scope of practice of athletic trainers. But if it reduces spontaneously, then hey, it's not like you're going to go to jail for that. that's good for the patient. Subluxation, on the other hand, is a little less severe than a dislocation, and this is where it is an incomplete dislocation. It's forced from normal position, but it remains in contact. So I could feel that shoulder kind of slip out and then pop back in place. That would probably be considered a subluxation rather than a dislocation. So with acute injuries, you may have learned RICE before, rest ice compression elevation. We've actually changed that and updated it to POLICE. Rest isn't necessarily ideal for acute injuries. We know that if we stick somebody in a cast, even if they're healthy, 4 weeks later when they come out, they're not going to be as healthy. So rest isn't the answer. Protecting that injured extremity from injury, further injury, is important. So we protect first, then we load it optimally. If it's a broken bone, we can't load it at all. They're going to be non-weight bearing, and that's optimal. Once they heal, then we start to reintroduce load. Okay. From there, we use our regular mnemonic, ice compression elevation. This is going to help minimize the inflammatory process. So ice promotes superficial vasoconstriction. It's going to minimize swelling. Also has some pain relief properties, and it helps save those injured cells. Compression, we can use something like a focal pad like this, an ACE bandage. If you're using a modality, something like a Game Ready has compression built in. Normatec is another one that has compression. Usually we're going to keep them compressed for the first few days following injury to help minimize the onset of swelling. And then just like we talked about with shock, elevation is going to be beneficial as well. So this is helpful in venous and lymph return. All right, well, that's all we have for today. There is another lesson this week, though, mostly dealing with bloodborne pathogens and infectious diseases. So we will stop there, and I will see you soon. Have a great day.